Okay, so the lateral collateral ligament on the lateral aspect of the knee has as its origin now the lateral epicondyle of the femur, whereas the medial collateral ligament was attached to the medial epicondyle. And the insertion of the lateral collateral ligament is onto the head of the fibula. It's interesting. The lateral collateral ligament has no direct attachment to the tibia bone. Rather, it's attached on the head of the fibula. Now, isolated lateral collateral ligament injury is rare. It more generally occurs as part of an injury to what's referred to as the posterolateral corner. And the lateral collateral ligament forms one layer of 3 layers of the posterolateral corner. So, injury to the lateral collateral ligament generally includes injury to one or more of the other components of the posterolateral corner, and may also involve injury to the anterior cruciate ligament and also the posterior cruciate ligament. So, like the medial collateral ligament, isolated injury to the lateral collateral ligament is rare, and so you must assess your examinee for combined injury to either the anterior or posterior cruciate ligaments, in which case the examinee would qualify for the highest impairment ratings for combined injury, which is provided for by the AMA guides. Now, with regards to the posterolateral corner, we can think of the lateral stabilization of the knee as occurring in 3 layers, with the superficial layer consisting of the fascia and connective tissue associated with the biceps femoris tendon, and the fascial tissue of the iliotibial tract, consisting of comprising the superficial layer, the lateral collateral ligament itself comprising the middle layer, and then the deepest layer is consisting of the posterolateral corner structures, including the popliteus tendon, the popliteofibular ligament, the arcuate ligament, and then also the posterolateral joint complex. So let's take a look at these structures. Okay, on the left here we have a depiction of the lateral collateral ligament, and it depicts the LCL here in isolation. Just remember that the lateral collateral ligament forms the second layer of 3 layers of lateral stabilizers of the knee. So here shows the lateral collateral ligament attaching or inserting or originating from the medial femoral condyle and attaching down to the head of the fibula here. And this particular diagram shows 3 grades of injury to the lateral collateral ligament: a grade 1, which is mild; grade 2, which is moderate and a complete rupture; grade 3, which is a severe injury to the lateral collateral ligament. Well, by the time injury gets into the lateral collateral ligament, many of the other structures of the lateral knee become involved, as depicted here on this diagram. So you can think of the lateral stabilization of the knee as being contributed to by 3 layers of structures. Most superficially, we have the connective tissue, the collagen tissue of the biceps tendon, and then also the iliotibial tract, which have been dissected away from their attachments here and across here, forming the most superficial support or restraint for lateral forces of the knee. Now, deep to the iliotibial tract and also the biceps femoris tendon, we have the lateral collateral ligament itself, which is depicted here. And you see how that's invested in the fascial tissue. So that extends from here. It's been dissected in this diagram right through here. And then here is its proximal portion to attach here on the lateral femoral epicondyle. So that's the intermediate layer of lateral support. And then we have the innermost structures comprising what's referred to as the posterolateral corner, which includes the popliteofibular ligament here, the structure here, which goes from the popliteus tendon to the head of the fibula here. So that's a popliteofibular ligament there. Then we have the popliteus muscle, which is depicted here. We have the inner aspect of the joint capsule, posterolateral joint capsule, depicted deep to the lateral collateral ligament. We have the arcuate ligament depicted here, providing restraint, especially posteriorly and posterior laterally in the posterior aspect of the knee. And then finally, we have the popliteus tendon running from the popliteus muscle right through in this structure here. So this is the innermost stabilizers to lateral varus forces and posterolateral forces of the knee. With significant injury significant enough to impact the lateral collateral ligament, it's likely, if not probable, that there will also be injury to the posterolateral corner structures, and then also more superficial structures such as the iliotibial band and also the biceps femoris tendon. And this may cause you to think, what other types of impairments your examinee may qualify for. It may qualify for some impairments due to loss of strength, for example, for loss of strength in resisted knee flexion if the biceps tendon is involved. May also involve some weakness in the form of resisted hip abduction if the iliotibial band is involved. So always be thinking about different and alternative impairments that your examinee could possibly qualify for. Okay? So let's talk about the physical examination of these structures. And because there's so many structures involved in the lateral aspect of the knee, our physical examination is going to have to include many or several maneuvers to assess these structures. So to begin, lateral opening, in other words, resistance to varus forces, that's stabilized by the lateral collateral ligament with secondary restraint provided for by the popliteofibular ligament here. Popliteofibular ligament here. And then also is stabilized by both the anterior and the posterior cruciate ligaments. So this may be another example when you detect excessive lateral opening of the knee joint that could suggest a combined injury qualifying the examinee for impairment due to collateral and cruciate ligament damage. Posterolateral rotation forces are stabilized by the popliteofibular ligament primarily, with secondary restraint provided by the lateral collateral ligament and then also the popliteus tendon, which runs right through here. Okay, so let's talk about how to assess these structures. Okay, so to begin, we begin with a simple varus stress test. And like the valgus stress test for the assessment of the medial collateral ligament, we're going to first perform the varus stress test at full extension and then again at 15 degrees of knee joint flexion. So in full extension, if we detect slightly increased lateral opening of the knee joint, that's going to suggest injury to the lateral collateral ligament and to the posterolateral corner structures. Now it's going to be virtually impossible to detect which of the posterolateral corner structures are involved, but it suggests to us that one or more of those structures are involved when we have laxity on full extension. Now, if the lateral opening advances from slight to moderate, or in general more opening, that also is going to suggest injury to additional structures such as the posterior cruciate ligament and or the anterior cruciate ligament, as one or more of those ligaments fail to allow more lateral opening of the knee. So this would be an example of a combined ligament injury involving the collateral and the cruciate ligament. And then at 15 degrees of flexion, increased lateral opening now at 15 degrees of flexion is going to suggest injury to the lateral collateral ligament, and then also possibly additional posterolateral corner structures. Okay, so we're going to assess at both full extension and then also at 15 degrees of flexion. So that test is done supine. Then the next test, the passive external rotation of the tibia, relative to the femur, that is. This is performed with the patient prone, and we want to perform this maneuver at both 30 degrees of knee flexion and then also again at 90 degrees of knee flexion. So when the knee is at 30 degrees of flexion and we have an increased external rotation that disappears at the 90 degree position, this indicates an isolated posterolateral corner injury, as the posterolateral corner structures are the primary restraints to external rotation when the knee is at approximately 30 degrees of flexion. Now, when we have increased external rotation at both 30 and 90 degrees, what's that going to indicate? Well, it's going to indicate injury to the posterolateral corner and also suggests combined injury to the posterior cruciate ligament. And any external rotation of greater than 10 degrees side-to-side comparison is considered significant. So always compare your findings on the involved lower extremity to your findings with the uninvolved lower extremity. And the distinction between these two tests is that when you have increased external rotation at the 90 degree position, that suggests a more serious and severe injury. It suggests a combined injury that would qualify the examinee for the highest permanent impairment rating. Okay? And the literature describes a few other tests as well, none of which seem to be particularly specific to either collateral or cruciate ligament damage. But the literature talks about the external rotation ray curvatum test, the reversed pivot shift test, and probably the most applicable and the most practical is the posterior drawer test with the foot in external rotation. And with the foot in external rotation, you as the examiner would simply apply a posteriorly directed force to the tibia on the femur. And if there is posterolateral rotatory instability, you will detect this on this maneuver. You'll detect this as the tibia subluxes posteriorly relative to the femur. Okay, so that is the lateral collateral ligament. And again, in an isolated lateral collateral ligament injury, which is rare, the AMA guides provide for 3, 7, and 10% whole person impairment. But as we've seen, injury to the lateral collateral ligament generally involves other structures, including one or more of the cruciate ligaments, and so those combined injuries qualify for much higher permanent impairment ratings. So it would be the exceptional case that qualifies for isolated injury, and it would be the more general case, the more numerous cases, the more common cases that qualify for the higher impairment ratings because of the co-occurrence of collateral and cruciate ligament injuries simultaneously. Okay, so always assess your examinee for all the ligamentous structures around the knee and be forever aware and attuned to the possibility of the coexistence of these combined ligamentous injuries. Okay,